Wound healing, the basics on the cellular and biochemical levels, the inflammatory stage of healing. The inflammatory stage of healing is considered by many investigators and clinicians to be the first stage of healing. I am not in that camp. It is a small point, but I believe control of bleeding is the first step in the healing of wounds because bleeding must be stopped. Many cells and chemicals are released while bleeding is being controlled that are responsible for inflammation and the subsequent stages of proliferation and maturation to occur. It should also be understood that these stages of healing are dependent upon each other and the stages overlap. In a special sense, it is actually one continuous process, but dividing the healing process into stages helps discussion of the events occurring in the healing. So what is the inflammatory stage of healing? Simply, the inflammatory stage of healing helps to clean up the wound. Think about when an injury occurs. The tissues are damaged. These tissues are the skin, the subcutaneous tissues like fat or the blood vessels, or maybe the deeper tissues like muscle or bone. Bacteria enter the wound through the break in the integrity of the skin. Many funguses may be present in the wound if the injury occurred in a laboratory or in the woods. Maybe in the wound are viruses from an accidental stick in a hospital or a veterinary clinic. Even with universal precautions, accidental sticks do occur. There may be road rash debris in the wound from a motor vehicle accident or a farm injury. Regardless of what is below the skin level, microbiological organisms or foreign bodies, it must be removed or destroyed for healing to occur. This is what is happening in the inflammatory stage of healing. Also in the inflammatory stage of healing are biochemical events that are setting up conditions to enter the next stage of healing. So let's begin with a quick review of lessons 1 and 2 of wound healing, the basics of cellular and biochemical levels, hemostasis, and let's add some more detail. A platelet plug was formed and stabilized with the formation of fibrin, the end result of the clotting cascade. The smooth muscle layer constricts as a reflex to narrow the vessel lumen to control bleeding. This reflex begins with the disruption of the blood vessel membrane, which releases two substances called prostaglandins and thromboxanes. These substances cause the smooth muscles to constrict. This was not mentioned in lessons 1 and 2. But this constriction lasts for only a short while, say 10 to 15 minutes. As a student, what has always surprised me in the next step was vasodilatation. The blood vessels dilate and become more porous. This is achieved by the substance histamine. So why would a vessel dilate after it constricts to control bleeding? An increase in porosity allows proteins within the blood to escape from the blood vessels. As proteins leave the blood vessels, water from the vessels leave as well. I think of this like osmosis. As there is a greater concentration of proteins on one side of a membrane, water moves through the membrane to equalize the concentrations. This movement of water contributes to swelling of the local tissues. Another concept to keep in mind about increased porosity is the assistance in cell migration. Cells within the blood move from the blood into the injured tissue. A porous vessel allows this to happen more easily. So you may be asking what cells leave the blood vessels in the inflammatory stage of healing. There is a cell called the polymorphonuclear neutrophil, PMN for short, that arrives in the wound first. Another cell is a lymphocyte called a T helper cell. These cells secrete a chemical, a cytokine, which further dilates the blood vessels. First, let's talk about the PMNs. It is the most common cell in a fresh wound during days 1 and 2. It functions to destroy bacteria and debris. This debris can be foreign bodies or injured tissue. The PMNs receive signals from other cells in the wound. Remember in lessons 1 and 2, the platelets released granules. These granules contain some of the signals that activate the PMNs. Once the PMNs have done their jobs, the PMNs undergo a process called apoptosis, which is thought of as a self-destruct mechanism. The remnants of this self-destruct mechanism are further destroyed by another cell called the macrophage. The macrophage is the most common cell in the wound after days 3 to 4. Its origin is the monocyte, which is another cell in the blood. It is interesting that half of the monocytes are held in reserve in the spleen, which is an organ in the left side of the abdominal cavity. Once a monocyte migrates into the wound through the porous blood vessels, it becomes a macrophage. It is an interesting observation that if macrophages are not present in the wound, a wound does not heal. I think the macrophage is one of the most interesting cells to study in wound healing. Like a PMM, the macrophage destroys bacteria and injured tissues and debris within the wound. They also secrete many growth factors and cytokines, which are important chemicals which set up the next phase of wound healing. This next phase is called the proliferative phase, and it will be discussed in the next lesson. Another interesting aspect of the macrophage is the rate it stimulates growth of new blood vessels. This process is called angiogenesis. If a wound does not have blood vessels to carry blood into the wound, then healing will not occur. Granulation tissue, which is chock full of blood vessels, is important for wound healing. The epithelial cells on the outer layer of skin must also be activated to migrate from the edge of the wound to cover the wound itself. Finally, collagen must be present to help stabilize the wound. I think of collagen as scaffolding over which cells migrating into the wound can occur. These events are initiated by the macrophage. It is really an interesting cell to study. Clinical implications. The timing of cell migration into a wound is important to understand because it has clinical implications. The PMNs are the first cells in the wound on days 1 and 2, and the monocyte enters about day 2 and become macrophages on days 3 to 4. Occasionally, I will have a patient in the office that places topical antimicrobial ointments on an open wound every day, and some will place the ointments several times a day for weeks on end. These topical antimicrobials are numerous, and like any other medicine, if they are used appropriately, then they contribute to healing. If used inappropriately, then healing can be delayed. Sometimes these wounds can close slowly or do not close at all. I usually find out about the daily application of topical antimicrobials during the history of present illness of the H&P. People will say to me, "I don't want my wound to become infected, so I placed antibiotics on the wound." If it is not mentioned or picked up in the HPI, then the clinical clue for me is an open wound for weeks without any signs of infection. In such cases, I will explain that these topical antimicrobials are very toxic to the bacterial cells and to the individual cells that are required to close the wound, like macrophages and PMNs and fibroblasts. If one kills the reparative cells, then the wound progress stops. In these cases, I simply tell the patient to stop using the antimicrobials and continue basic wound care and dressings, and the healing resumes. This usually closes the wound within a week or two. Another interesting clinical aspect of inflammation is what happens if inflammation continues without progressing to the proliferative stage of healing. Simply, this condition will lead to a chronic open wound. Inflammation stays as long as debris such as dirt and dead tissue exists in the wound. Chronic open wounds appear to be stuck in the inflammatory stage of healing. Clinicians for millennia have known this situation well. By changing a chronic wound into an acute wound, healing will resume. To make this change, a surgeon will debride the wound of dead tissue and foreign objects. The process of healing resumes by first controlling the bleeding from the debridement procedure, and the process starts over. Hopefully, during the debridement procedure, any remaining dead tissue and debris is removed. Our next lesson will cover the proliferative phase of healing. It is a long discussion. Thanks.